Okay, hopefully we're going. And feel free to unmute yourself if you have a question, or if you feel more comfortable typing in the chat box too, that's fine. I don't mind either way. I will try to keep an eye on the chat. Okay. So tonight I'm going to go over the first 5 lectures. I thought it kind of made sense to do all of the pharmacokinetic and pharmacodynamic lectures together. And then in my session on Wednesday night, I'll cover all the antibiotics. And then the following Sunday, I'm hoping to have like a review, like another practice question session before your exam. All right. Okay, so let's start with lecture 1 here. And if everybody can make sure that their mic is muted, that would be awesome. Okay. Okay, so first of all, for Dr. Weaver, I'm sure you guys have heard this, but anytime she puts something in red, that's her way of saying, this is very... Hey, whoever has their mic on, can you mute it, please? Thank you. Okay, so yeah, Dr. Weaver, whatever she has in red, that's very important. That's very high yield. That's not to say that I would go crazy about deleting anything that's not in red, because sometimes those things that are not in red are important, like foundational information to understand that big concept. So yes, focus on what's in red, but don't completely ignore everything else. But that being said, like Dr. Weaver is extremely fair, and like she said, you can definitely trust her. Okay, so the first big topic here is going to be clinical trials, and I'm focusing on what she had in red, and we definitely had a question related to this last year. So make sure you know what is included in each of the 4 phases of clinical trials. So in phase 1, if the question talks about giving the drug to healthy volunteers, then this is cluing you in that it's phase 1. And you're also looking at the drug's pharmacokinetic and pharmacodynamic profile. So just real quickly, can somebody give me kind of a simple definition of pharmacokinetics? What does that mean? You could probably describe pharmacokinetics in like 5 or 6 words. Right, exactly. It's what your body does to the drug, and then how would you describe pharmacodynamics? So pharmacodynamics would just be the reverse of that, what the drug does to the body. So if they talk about, we gave, drug X to healthy volunteers, and we're looking at, what does the body do to this drug? It's likely phase 1. Whereas in phase 2, they're going to describe giving the drug to people who have the disease. So if they're talking about volunteers that have the disease, you can definitely rule out phase 1. And then in phase 3, if you see a stem talking about randomized controlled trials, that would be a hint that you're talking about phase 3. Or also it might mention something about labeling. So labeling is where they come up with the product package insert, and this is the indication for the drug or what the drug is used for. And then in phase 4, you're talking about post-marketing surveillance. So in phase 4, you're giving the drug to a large, diverse population, and you're just looking for those idiosyncratic or rare side effects. So when you talk about a black box warning being added to a drug, it's probably happening in phase 4. Okay, so I got this chart from Amboss, and I don't know, did anybody watch Morgan's video that was posted by Caleb? Did you guys see that? Morgan's video, like his advice about being a Mediasider. Yeah, so one of the things that he recommended and is really great, you can like type in like pretty much any med school related topic and put Amboss after it, and it's going to give you, I mean, obviously you just have to ignore this, but it's going to give you a really great explanation of, whatever you're looking for. So this is pharmacokinetics. So as you can see, there's tons of great information on there. So just FYI on that. Okay, next. Okay, so the next thing that's really important for the exam is how drugs are classified. And the two that she's probably going to focus on are the non-legend or over-the-counter drugs and the legend drugs, which include controlled substances. So if it's an over-the-counter drug, and say you write that prescription for the patient, that prescription is going to be valid for 1 year from the date you wrote it. So this would be something like, Tylenol, ibuprofen, anything that you can get in the pharmacy aisle, at Walmart. Legend drugs are going to be things that are not available over the counter, but they're not necessarily controlled substances. So say, for example, something like Viagra, sildenafil, that's going to be a legend drug. So if you were to write a patient a prescription for that, it's also going to be valid for 1 year from the date it's written, unless you're talking about a controlled substance. So controlled substances are scheduled by the DEA, and we have schedules 1 through 5, and they're classified based upon their risk for dependency and abuse. And that starts with Schedule 2. So Schedule 1, she mentioned in class, would be like marijuana. It cannot be prescribed for medical purposes in the US. But starting with Schedule 2, you're talking about drugs that have the highest risk for dependency and abuse. So something like an opiate, that would be a Schedule 2 drug. A Schedule 3 drug, and I got this from the DEA website down in the bottom corner there. I gave you a link if you want to read more about this. But Schedule 3 would be something like testosterone or products containing less than 90 milligrams of codeine. Schedule 4 would be something like alprazolam, which is Xanax, or diazepam, which is Valium. And then Schedule 5 is something like pregabalin or Lyrica. So Schedule 5, you're looking at the drugs with least risks for abuse or dependency. Where your test question is probably going to come from is from the Schedule 2 drugs. So anytime you prescribe a drug that's considered Schedule 2 or Class 2, you have to write that prescription, and it cannot be refilled. So, but a lot of times, you don't want the patient. Yeah, right. Schedule, so class 1 through 5, they're all legend drugs, but they fall under the category of controlled substances. So controlled substances fall under legend drugs. So let's see, what I was saying is, like say, you prescribe the patient a Schedule 2 drug, but you don't want to make the patient come back a month from now. What you can do is write out 3 separate prescriptions, and like one says June 1st, one says July 1st, one says August 1st, and then you write do not fill before that date. That way the patient has to present that written prescription to the pharmacy, and they cannot get it refilled before the appropriate time. So just make sure you kind of understand how that works. Okay. So next, you need to understand the difference between a side effect and an allergy. So an allergy is an adaptive immune response to an antigen, while a side effect is a predictable dose-related expression of the drug's activity. So basically think of an allergy as an immune response and a side effect as, just a predictable response to what the drug is doing. So when we talk about allergies, the 2 most common are an immediate reaction or a delayed reaction. So your immediate reaction would be a type 1 hypersensitivity reaction. And what's most commonly tested is an anaphylactic reaction. A delayed reaction would be type 4 hypersensitivity. And one that's commonly brought up is a TB test. So, I'm sure, in fact, all of you have gotten a TB test because I think it was required before you started at DCOM. So, you get your TB test, and basically they're waiting for a response to that test. So that's an example of a type 4 hypersensitivity reaction that's commonly tested, and it's delayed, and that's why you have to wait. I think it's 48 to 72 hours for that response to happen. Okay, and I have a practice question over this, so we're going to come back to all of this. Okay, yeah, and I've also clipped in a lot of references from first aid. So I have a paper copy of 2020, but the most recent PDF I have is 2018. So if somebody has a more recent copy that they'd like me to use, if you want to email it to me, I'd be happy to use that in the future. But for right now, I'll be referencing 2018. So yeah, I think you guys just had a test on this, but just take a second to review type 1 versus type 4 hypersensitivity. Okay. And I believe the last thing for this lecture is just making sure that you know what should be on your prescription. So, of course, you need the patient name, the date it's written, the name, the form, the strength of the drug, how much you're dispensing, the directions, how many refills, a signature. Your DEA number is very important if you're prescribing a controlled substance. I feel like this was an exam question, but I really don't remember how she asked it. This is pretty straightforward though, so just make sure that you're familiar with, if you're writing a prescription, what's got to be on there. And you should be fine with whatever she asked you. Okay, so let's get to the practice questions now. All right. So I wrote most of these on my own. So if you have an issue with them, let me know. You think there could be 2 answers, or the question sucks, just let me know. I won't be offended at all. Okay, so hydroxychloroquine is administered to 150 patients with SARS-CoV-2 to test for efficacy in treating the novel coronavirus. This drug is likely in which phase of clinical trials? Right? Good job, you guys. So the answer for that one is B. So the two things you're looking for here would be the fact that it's given to patients who have the disease, and you're looking for efficacy. So that tells you that it's phase 2. Okay, so next question. A boxed warning is most likely to be added in which phase of clinical trials? Right, D. Phase 4, that's where you're looking for the rare side effects. So this is most likely where you're going to get a boxed warning at, because the drug's being given at that point to a very large population of people. Okay. A 25-year-old female patient asked for a prescription for ibuprofen so she can use the remainder of her flexible spending account funds before the end of the year. She says, "How long do I have to fill this prescription?" What is your reply? Yep, good job. So she's going to have 1 year to refill it because it's an over-the-counter medication. Okay. Next one, you decide to prescribe a 70-year-old male patient with stage 4 non-small cell lung cancer transdermal fentanyl for pain. What is the most appropriate way to write his prescription? Right, you guys got it. So you want to write 3 separate prescriptions on your pad, date with the appropriate date, and write "do not refill before" on each prescription, because transdermal fentanyl is a Schedule 2 controlled substance. Okay. A 48-year-old male patient informs you that he cannot take oxycodone for his post-operative pain because he is allergic. You ask him what happens when he takes oxycodone, and he replies, "It makes me so sleepy that I fall asleep sitting up in my chair." What is the most appropriate response? Right, good job. So you're going to explain to him that drowsiness is to be expected because it's a common side effect of oxycodone. So hopefully this shows you kind of a way that she could ask you for the difference between an allergy and a side effect in a question. Okay. Any questions before we go into lecture 2? Okay. If not, I'm going to keep going. Okay. So we'll start with the first pass effect. So understanding this is very important to understanding the concept of bioavailability. So I just want to make sure that, I dedicated a slide to this. So in the first pass effect, the concentration of a drug is greatly reduced before it reaches the systemic circulation. So after the drug is swallowed, it's absorbed by the digestive system, and it's going to enter the hepatic portal system. It's carried through the portal vein into the liver before it reaches the rest of the body, and the liver is going to metabolize the drug and reduce the amount of active drug that emerges from the liver and enters the systemic circulation. So the reason that this is important is because drugs with a higher first pass metabolism are going to have a higher oral dose than sublingual or parenteral dose, like an IV dose, because you have to compensate for that first pass effect, because less drug is going to reach the systemic circulation, and less of the drug is going to be bioavailable. Okay, So let's go over some of the routes of administration real quick. So enteral routes include sublingual, buccal, and PR, which is per rectum. And you could definitely trust Dr. Weaver here. The only thing you really need to know is what's in red. So any of these three are going to bypass the GI environment and bypass the first pass through the liver. If you're giving it orally, the drug is going to be exposed to the harsh gastric environment and it's going to enter the hepatic portal circulation, which means it's going to be exposed to that first pass effect. Okay. So next we have the parenteral routes. So the most important one here is the IV route. And something you want to make sure you know is that if you give a drug intravenously, that it is going to be 100% bioavailable. And the reason this is because you're injecting the drug directly into the systemic circulation. So if the drug is entering the blood, all of the drug is available right off the bat, and you don't have to wait for that first pass effect to see what you're going to be left with. Okay. So again, bioavailability. So that's the fraction of the drug reaching the systemic circulation unchanged. And the big thing to take away from this is that an IV dose has 100% bioavailability because you're putting the drug directly into the systemic circulation. So if these are the examples she gave in class, and absolutely don't worry about the percentages. It's just the concept that you need to understand. So something like azithromycin is only 32 or 34 to 52% bioavailable. So the reason this is important is because the oral dose will be much different than the parenteral dose. So chances are you're going to have a much higher oral dose than parenteral dose to get the same effect, because it's only less than 50% bioavailable once it reaches the systemic circulation. Whereas something like levofloxacin, you can easily switch between IV and PO because it has 99% bioavailability. So you're really not seeing a change there, regardless of which route you choose. And then the last example she gave was levothyroxine, which has a variable bioavailability based upon, the state of the body when you take the drug. So something like levothyroxine, which is free T4, you're going to have a better bioavailability in the morning if you take it before eating. So this is kind of like the rationale between some of the routes of administration and the dosing directions and how you take the drug. Okay. So our last couple of parenteral routes are going to be sub-Q, ID, which is intradermal, and IM, which is intramuscular. And these are important because the absorptive phase is going to delay the onset of the drug. So if you want the drug to last over a longer period of time, choosing one of these routes might be most appropriate. So I think the one that a lot of us, at least females, are probably most familiar with would be the depot injections. So this is an example, of an injection where, you're going to prolong the duration by delaying liberation. Okay. All right, so this will definitely be a test question. It was last year, and I noticed when I listened to the lecture, she said, straight out that this is going to be on the exam. So I tried to, um, I don't know. I don't know if more words or fewer words are better, but what I recommend is if you go to the next slide, that chart, that chart is all you need to get this question right on the exam. But I went ahead and if you're a words person, it's written out in words here. Okay, so let's go through it. So unionized drugs generally pass more readily through non-fenestrated membranes. So if you have an acidic drug, it's going to be unionized in an acidic medium because acid drugs can't donate a proton when there's already too many protons around. So if you're in an acidic medium, you already have plenty of protons around, and your acid is not going to give up any more protons. Whereas alkaline drugs are going to be unionized in an alkaline environment because there aren't any protons around. Okay, and then alkaline drugs will be ionized in an acidic medium because these drugs will pick up a proton to carry a charge. And then acidic drugs will be ionized in an alkaline environment because they can readily donate their proton. Okay, so drugs that are trapped in the urine are considered irreversibly eliminated. So what type of environment do we need to trap acidic drugs? Acidic drugs are going to be ionized in an alkaline environment. Okay, so remember, the ionized form of the drug is the trap form. And then what type of environment do we need to trap an alkaline drug? So basic drugs will be ionized in acidic urine. Okay, so this is kind of saying the same thing as this, but I'm hoping that if this is confusing, you go back and you read through this a few times, with fresh eyes, that it's eventually going to click. And I do have some practice questions, so hopefully that helps as well. All right, so let's keep going. Okay, so this chart, I promise, this is all you need to know to get the question correct. So acidic drugs in an acidic environment are going to be unionized. In an alkaline environment, they're going to be ionized because they can give up their hydrogen ions. Okay, and then basic drugs in an acidic environment are going to be ionized, and in an alkaline environment are going to be unionized. So my advice, if you get to the point where you're just like, I can't even, right, associate trapped with ionized. That's, 100% correct. So if you're not a chemistry person and you're just like, I can't even do this, all you need to do is memorize this chart and you will get that question correct on the exam. But I mean, ideally, of course, you're going to understand it. So I have some practice questions for this. So we're going to keep going for now. Okay, so again, here's a little clip out of first aid. Weak acids are trapped in basic environments, and weak bases are trapped in acidic environments. Okay. Okay, so drug distribution. Really, everything you need to know is summed up right here in this little chart. But a drug with low distribution is going to be hydrophilic or plasma protein bound because it wants to stay in the blood. So since it's not leaving the blood, it's going to be lowly distributed to the tissues. And then anything with a large molecular weight has low distribution, or anything that's charged. Hold on. Are ionized drugs always going to be excreted in the urine, or is it only if it's already in the nephron? I'm trying to think about your question. As far as I know, yes, ionized drugs are going to be excreted in the urine because they're being trapped. But again, it all has to do with what type of an environment the urine is. Is your urine acidic or is your urine alkaline? And one thing we do to change that is to administer different antidotes to a drug. So an antidote is going to alter the environment, and that is going to ionize the drug and trap it. That way it's eliminated from the body. Does that sort of make sense? If it doesn't, I think once you see a few practice questions, it might help. Okay, so anything that's highly distributed is going to be uncharged with small molecular weight, and it's going to be lipophilic or hydrophobic, meaning it doesn't want to stay in the blood, so it wants to get out into the body. So all of this, it's consistent over here. So low distribution is intravascular. Those are large charged molecules which aren't crossing the membrane or plasma protein bound, staying in the blood. And then high distribution, so when we talk about distribution, you're talking about distribution to the tissues, how well it's leaving the systemic circulation and it's reaching the rest of the body. So drugs that are going to be highly distributed are small, lipophilic, and yeah. So, I would, just focus on this chart here and what's here. Okay. All right, so when she talks about clearance, she used a lot of slides to kind of just make this point here that clearance is equal to the volume of distribution times the elimination constant. So you don't really need to memorize, how this equation is derived. Just memorize this right here. Clearance is VD times KE. And that's when she talked about clearly Cali multiplies VD. So this is the one you need to think about. All right. Okay. And then for zero and first order elimination, I feel like this little excerpt from first aid, tells you everything that you need to know. So I kind of skipped her slides with this. Okay, so zero order elimination. Zero order is a constant amount of drug eliminated versus first order, which is a constant fraction of drug eliminated. And the two that she said you need to know follow zero order kinetics are, I think it was ethanol and aspirin. But if you want a mnemonic, obviously this is out of first aid, so you need to know it eventually. The mnemonic is P. So phenytoin, ethanol, and aspirin all follow zero order kinetics. Let's see. The other important thing to realize would be how to calculate half-life by looking at a graph. But I'm going to skip that for now because I have practice questions to go over that. But just make sure you know how to calculate half-life by looking at a graph. So we'll go over that in just a minute. Okay, so time for some practice questions. Which of the following routes of administration has the highest bioavailability? Right. So the correct answer is B, intravascular or IV administration. Okay, and hopefully, so I clipped this out of her lecture, but I think it does a really good job of explaining the difference between concentration and distribution. Okay, so let's start with the left side over here. It would be what concentration and what distribution, high or low. So this guy right here. Right, good job, Andrea. Yeah, so it's high concentration and low distribution. So concentration is referring to the concentration of the drug in the vasculature, and distribution is referring to the distribution of the drug in the tissues. So right now it's in the systemic circulation, but it's not in the tissues. It's not in the entire body. Okay, so what would this side be? The right side. Anybody? Right, low concentration, high distribution. Yeah, that's right. So it's highly distributed because it's all over the body or all over the tissues. Okay. All right, so what is the impact of protein binding on apparent volume of distribution? Right, so the correct answer on this one is C. So remember, a protein-bound drug is going to want to stay in the blood. So it's going to want to stay in the systemic circulation. And if you're not being distributed to the tissues, you have a low volume of distribution. So the drug wants to stay in the blood, resulting in a low volume of distribution. All right. I think this one's a little tougher. We'll see. So which statement best describes the impact of lipophilicity on apparent VD? Would you have to specify protein binding be a plasma protein or tissue protein? Yeah, that's probably a good point. Yeah, I suppose you'd have to specify plasma protein binding to like make that a really well-written question. Okay. Okay. Yeah, no problem. All right, so for this one, if a drug is lipophobic, does that mean it's hydrophobic or hydrophilic? Right, so if a drug is lipophobic, that means it's hydrophilic. So if something is hydrophilic, does it want to stay in the vasculature or leave the vasculature? If it likes water. Right, it wants to stay in the vasculature. Yeah, it wants to stay in the vasculature. So if it wants to stay in the vasculature, does it have a low volume of distribution or a high volume of distribution? Low, right. Okay, so then what would be the correct answer for this one? Right, B. Good job, you guys. Is everyone okay with that? That was definitely one of my tougher ones. That's about as tough as I can get. All right, let's go to the next one. The molecules in a drug with the ability to readily cross the blood-brain barrier can be described as which of the following? Right. Good job, you guys. Small and lipophilic. Okay, so I put a star on this one because I'm pretty sure this question was almost verbatim on the exam. Like, this was one of those questions, that are just like give me's. Like every exam, there's kind of like a give me question that everybody gets right. Pretty sure that this one was it. And when I was re-listening to the lectures today, I think she mentioned this in almost every lecture, so make sure you know this. So the correct answer for this one is B, right? 4 to 5 half-lives to steady state. Okay. A patient was given 100 milligrams of drug X at 12 p.m. If the drug has a half-life of 3 hours, how much of the drug remains at 6 p.m.? Right, good job. So 25. Is everyone good with that? So at 3 p.m., how much of the drug would be left? Just to make sure we got it. Right, C, 50 milligrams. Okay. Next question. Okay, here's what I was talking about, the half-life. Yeah, this graph was from her lecture. You're going to get something extremely similar on the exam. So what is the half-life represented by graph A? Right, B. So all you need to do is look at the y-axis. How long does it take to get, from either 8 to 4 or 4 to 2? So from 4 to 2, here's 4 is 8 hours to 2 is 12 hours, so 4 hours. So a half-life of 4 hours. Okay. So make sure you're prepared for that. And I think if you took biochem in undergrad, I feel like this is something that they really focused a lot on. All right, lecture 3. So phase 1 and phase 2 metabolism, I wouldn't worry so much about, what exactly is phase 1, what exactly is phase 2, as I would some of the examples that she gave as far as the charts. But, just to go through it, so phase 1, you add or unmask a reactive functional group through reduction, oxidation, or hydrolysis. Also in phase 1 is when your CYP450 enzymes come into play and you get enzyme induction or enzyme inhibition. And then in phase 2, the big thing to know is that you're conjugating reactive groups with highly polar moieties. So basically, the point of this is making something more polar to trap it outside the body, outside meaning in the GI tract or in the renal tubule for either biliary or renal elimination. I wouldn't get so caught up in the chemistry of all that. She's not going to test you on that. It's going to be over all the examples that she worked in class. Okay. So this is really important to look at. So you want to make sure that you understand what's going on here. So if We have an active drug that's metabolized by a CYP enzyme to an inactive drug, and we give somebody an inhibitor of that CYP enzyme, we're going to have an increase in the amount of active drug. Because since the CYP enzyme is metabolizing it from active to inactive, if you inhibit it, so draw your X there, you have an increase in active drug. And then here I've just basically drawn out what she drew out in class. So if you give a drug that's a CYP inducer, you're either going to have more active drug or more of a toxic effect. And then here, getting less than you expect. So if you give a CYP inhibitor and the CYP enzyme metabolizes the prodrug to the active drug, if you inhibit that, you're going to get more of the prodrug. So I think the biggest example that she tested last year was giving an inhibitor. So this idea that if you inhibit an inhibitor, you get more of what you started with, that's something that I would give some thought to. And again, I have practice questions, so I'm just going to keep going. Okay. This is also important. I'm not sure if this is on the first exam. This may have been a Dr. Babos question, but make sure you know that N-acetylcysteine is the antidote to acetaminophen overdose. So N-acetylcysteine is going to regenerate glutathione. So if you regenerate glutathione in the minor pathway, you get renal excretion instead of renal damage. But the thing I think she focused on was the fact that if basically you're drinking and taking a lot of Tylenol, that the alcohol is going to compete with acetaminophen. So if you stop drinking, the CYP2E1 remains induced and you're shifted towards this minor pathway, which leads to this right here, this NAPQI, which is a toxic metabolite, and it leads you down this pathway to liver damage. Okay. Okay, so again, how many half-lives to reach steady state? 4 to 5. Make sure you know that. What is steady state? So steady state is the rate of drug in. I believe it should be equals there. So the rate of drug in is equal to the rate of drug out. So the reason that we give a loading dose is to shorten the time to achieve steady state drug concentration. Okay, not the actual time it takes to reach steady state. So if you look over here, 4 to 5 half-lives to get to a steady state. If you have somebody who's in critical condition, you don't have time. You can't wait 4 to 5 half-lives to achieve that concentration. So you're going to give them a loading dose, and that allows you to reach the steady state concentration much faster, which of course can be beneficial to the patient. Okay. First practice question. A 25-year-old patient presents to the emergency department with an overdose on aspirin. In order to promote excretion of aspirin from her body, an antidote that does which of the following would trap the drug in the urine? So what would you want to do to the urine in order to trap aspirin? Right, so A is the correct answer. You want to create an environment where the pH is greater than the pKa, so an alkaline environment. So once the antidote is administered, does aspirin become ionized or unionized? Right, it becomes ionized because it's giving up its protons in that alkaline environment, and then it's ionized. So ionized means it's trapped, which means it's going to be eliminated. Okay. And like she said, you're definitely going to have a question on your exam that, tests whether or not you understand this. So make sure you got this down. And I definitely recommend drawing out that little chart that she has, with unionized versus ionized. Draw that chart out on your scrap paper because if you get it, this is an easy question, but when you're tired and stressed because it's a block exam, it's easy to get this backwards and miss it. So I would definitely, recommend that you draw that chart. Okay. So this is directly out of her lecture, but I just wanted to make sure that you understood it because you're going to see something similar to this. So nifedipine is a drug that reduces blood pressure. The metabolism of nifedipine to inactive product is catalyzed by CYP3A4. What do you expect to happen to blood pressure if a patient starts drinking? Sorry, I just realized I didn't include everything that should have been in this question. Okay, so I'm going to skip ahead here. So I edited this question to say if the patient starts drinking grapefruit juice, which is a CYP3A4 inhibitor, while taking nifedipine. So I'll just give this one to you. So the blood pressure is going to decrease because there's more active drug. And I wanted to show you how I draw these questions out. So this is the one that she likes to test on. So inhibiting the inducer, or inhibiting an inhibitor rather, is going to lead to more of the active drug. So if the patient starts drinking grapefruit juice, which inhibits CYP3A4, this is not going to happen. So your active nifedipine is not going to be converted to inactive nifedipine. So if that's the case and you have more active nifedipine, and active nifedipine lowers your blood pressure is going to decrease. So on that one B, blood pressure will decrease because there's more active drug. Are you guys okay with that? This is something that you definitely have to draw out on the exam. But I wanted to show you how I did it. I just thought maybe that would help. Okay, I have another one. Okay. A caffeine-achieving pharmacology professor quit smoking. Which outcome is likely with regard to our caffeine-related effects if smoking induces CYP1A2 and CYP1A2 deactivates caffeine? Right, so my main purpose here is to show you how I like to draw these out. I wouldn't assume, because like in this question, she tells you CYP1A2 deactivates caffeine. So since it deactivates caffeine, you can write active to inactive, and then CYP1A2. Yeah, she should tell you. I think this is like very on par with the exam. She's pretty fair. So hopefully I was hoping that seeing how I write this out would help you guys. So if smoking induces CYP1A2, if you stop smoking, this is not going to happen, and you're going to have more of the active drug, which would be caffeine. So make sure that you draw it out on the exam. Okay, lecture 4. Okay, so functional tolerance just refers to the fact that a higher dose of drug is required to produce the same response over time. And this is a result of a change in receptor sensitivity. So I think she talked about, she was prescribing or like filling a prescription for a cancer patient who was taking a very strong pain medication. And, in us, that amount probably would have killed us. But in that patient, because she had a functional tolerance, she required a much higher dose to get the same effect because the receptors were less sensitive to that drug over time. All right. This one. So this concept, I don't remember if it was on the exam last year, but we have been tested on it several times. I think, I know last year this question came up in EPC. So make sure you understand the difference between dependence, withdrawal, and addiction. So dependence is due to the up and down regulation of receptors. Um, and if you're dependent on a drug and you're no longer given that drug, like say you run out of it, then this can result in symptoms of withdrawal. So it's only known as addiction if the patient is using the drug in a way that has negative effects on daily functioning and financial well-being, social well-being, and or emotional well-being. So the big thing here is to realize that patients can be dependent on a drug without being addicted. So, a cancer patient who is dependent on a drug for pain relief, it wouldn't, be appropriate to say that they were addicted unless, they're selling their fentanyl patches for money. So make sure you understand the difference there. Okay. So this here is a big concept to understand. The difference between efficacy and potency. So when you talk about efficacy, that's the maximal effect that a drug can produce. So this is the drug's Vmax. When you talk about potency, this is the amount of drug given needed for a given effect. So, and she went through this several times. So anytime you have a decrease in the EC50, you have an increase in potency, which means that less drug is needed to reach that effect. All right. Okay, so this is an important one here. And I copied this from my tutor study guide last year. So she had several slides talking about competitive inhibitors, allosteric inhibitors, and whatnot. But if you just know what is on the slide here, that's more than enough to get the question right. So this graph is probably one that you're going to see again. So if you have a drug plus an allosteric activator, this produces a synergistic effect. So you're going to have a higher Vmax. But the two that I would focus on would be a drug plus a competitive inhibitor. So B would be your competitive inhibitor, and then the drug plus an allosteric inhibitor. So if you have a drug plus a competitive inhibitor, the competitive inhibitor acts as a competitive antagonist, which is going to increase the EC50. So if you have an increase in EC50, you get a right shift. And this means that the drug is less potent. But it can be outcompeted to produce 100% Emax, so the efficacy stays the same. So remember, a competitive inhibitor, you're going to have decreased potency, but your efficacy will stay the same. Whereas in A plus D, which is the drug plus an allosteric inhibitor, it's going to act as a non-competitive antagonist. So because it's allosteric, it's not competing for the binding site. It's binding somewhere else, but it's still acting as an inhibitor. And your EC50 is not going to change. So you'll have the same potency, but a decreased Emax, which means a decrease in efficacy. So really, all you need to know here, like to try to make it as simple as possible, is that with competitive antagonism, you're getting an increase in E50 and the same efficacy. With non-competitive antagonism, the EC50 does not change, and you're getting a decrease in efficacy. So, if you know what's here, I think you'll be fine with this question. Okay, and then again, I really like first aid. Like if you haven't cracked open first aid, or if you don't have a PDF copy, like let me know and I can send it to you. But this here just goes through the same thing. Okay, so with competitive antagonism, remember you get a right shift, and then in non-competitive antagonism, you get a downshift. So a decrease in potency versus a decrease in efficacy. All right. And then, okay, so the last thing for this lecture, know this little fact right here. So partial agonists can act like antagonists when combined with full agonists. So I think without a good example, this probably doesn't make a lot of sense, but this does come up a ton next year. So if you need an example, the one that came to mind was that, have you guys heard of Subutex? I feel like that's kind of a common thing. So if you have somebody that's being treated with Subutex, which is buprenorphine for opioid addiction, so Subutex is a partial agonist. If that person is undergoing treatment and taking Subutex, and they go out and they try to get their usual high, or use the usual opioid, that's going to precipitate withdrawal symptoms, because you're combining Subutex, which is a partial agonist, which with the real thing, a full opioid agonist. And those two things together are acting as an antagonist, which precipitate in withdrawal. Okay. All right, so practice question time. All right, which drug is more potent? Right. Yep, you guys are correct. Right, so drug B is more potent because it has a lower EC50. So ignore that. I'm just going to skip past that because I mislabeled the answer. So I'll correct these few mistakes I have here before I upload the answer version. Okay, so which drug is more efficacious? Drug A or drug B? Or are they equally efficacious? Right, so the correct answer is C. They're equally efficacious because they reach the same Emax. Okay. And this graph is from her lecture, but which line represents the drug that is more efficacious? Sorry, gave it away for you. Yeah, so the purple line, because it has a higher Vmax. So which line is more potent? Right, the green line, and why? Right, because it has the lower EC50. Yeah, so this is definitely an exam question, and it's going to be an easy one. So make sure you have this down. Efficacy versus potency. Okay, so which of the following is an action of a non-competitive antagonist? Right, so the answer here is D. So it's going to decrease the maximum response to the agonist. So what this means is it's decreasing your Emax. So make sure you can, kind of go through all the characteristics of competitive versus non-competitive. Would B and C be correct too? Okay, let me go back to the slide here. Okay. So non-competitive antagonists, so they're not going to change the EC50. So they're going to have the same potency, and they're going to decrease the Emax. So they're decreasing the response to the agonist. And then competitive antagonists are going to shift the dose response curve to the right. So they're going to increase the EC50 or decrease the potency. So you can also see this over here. So a right shift of the curve versus a decrease in the Emax. Does that make sense? Yeah. And then so if A was correct, you'd be talking about what type of inhibitor? Or what type of antagonism? Competitive or non-competitive? Right, competitive. Okay. All right, one more lecture. Almost done here. Okay. So this was an easy test question last year. So make sure you know the relationship between irinotecan and Gilbert syndrome. I guess it's not really mnemonic. I don't know what you call it. But the trick to remember this, you think about irinotecan, it means I run to the can. So death by diarrhea and or neutropenia in patients with Gilbert syndrome, which is a lack of UGT. So when UGT is in the epithelial cells of the intestine and it's defective, the toxic metabolite of irinotecan is going to accumulate. So the toxic metabolite is this SN38. So you can see it here accumulating in the gut epithelium, and it's going to kill the gut epithelial cells, leading to severe diarrhea. So the reason that this is a problem is because if you give someone with Gilbert syndrome irinotecan, you're probably going to kill the patient, because if the dose is high enough to have its therapeutic effect, which is killing cancer cells, yeah, that means your patient's in trouble, because they're going to present with, very severe diarrhea or neutropenia. Okay, so this can be deadly. So just, remember irinotecan in the presence of Gilbert syndrome can lead to the toxic metabolite, which leads to death to the toxic metabolite of irinotecan, right? So that's your SN38. It builds up, it kills your gut epithelium. This leads to very severe diarrhea, which is going to precipitate, and of course, dehydration and all sorts of electrolyte abnormalities. But, as long as you understand the pathophys to the point of just what's on this slide, like, you're going to be completely fine. Okay. So this comes up a lot next year. So the drugs that share a risk of causing an autoimmune disease that resembles lupus when the drug accumulates, these include sulfonamides, hydralazine, isoniazid, and procainamide. I wouldn't worry too much about what these drugs do. I honestly don't remember this being a question on the first exam, just because, you haven't been taught these drugs. But she did have it in red, so, just in case, the mnemonic is SHIP, and these are the 4 drugs that can cause a lupus-like syndrome if they accumulate. And the reason that this is important is that populations that share this NAT2 gene polymorphism, that makes them slow acetylators. So if you have this polymorphism, these drugs are not going to be metabolized as quickly. So you're going to get a buildup of these drugs, or this, say, like if the patient is being given hydralazine and they have this gene polymorphism, they're going to slowly acetylate this drug, so they're going to have a buildup of hydralazine, which is going to lead to the bad side effects of hydralazine, which is not something that you need to worry about right now. So just remember this mnemonic, and that they accumulate. You get an autoimmune disease that resembles lupus, and you should be good. Okay, so she talked about the therapeutic index. I would just know the equation for this, and then what the therapeutic index is. So the mnemonic that first aid gives is TIGHT, so therapeutic index is equal to the ED50 the TD50 divided by the ED50. You won't be asked to do any math, at least I don't remember being asked to do math, but you might be asked for the equation. Okay. Okay, so a few more practice questions. A patient is found to have an autoimmune disorder that's very similar to lupus in presentation. The physician is sure that the disease is not lupus and that is drug-induced. Which of the following drugs would not cause this disorder? Right, you're correct. So instead of ibuprofen, what was the I drug in that mnemonic? Isoniazid, right? Okay. Cocaine, which is a base, and warfarin, which is an acid, are being filtered through the kidneys. The urine in this patient has a pH of 4.5, so more of which drug will be excreted in the urine. So which drug is going to be trapped? Right. So cocaine, and does somebody want to explain why, like their logic? Like how did you answer this question? Right, good job, Haley. Okay. Um, you will probably see this image on the exam. So if you see the bite cells, you're going to associate this orphan. Just a second. I'll come back to your question in just a second. Let's finish up these last few, and then we can go back to that one. No, yeah, it's totally fine. Okay. So if you see these bite cells, what are you going to associate this image with? Right, G6PD, and I think she had, um, almost this exact image of it on the exam. So the question's going to be, very, very comparable to like the example that she gave you in class. So yeah, just make sure that you can recognize the presentation of G6PD. So the yellow sclera, the abdominal pain, the itchiness, and then recognize this histology image, and you won't have any problem getting that question right. Okay, so there was definitely one or two questions like this on the exam last year. So make sure, and she will give you a chart like this. You don't need to memorize any of the CYP enzymes. It's just, your ability to interpret the chart. Okay, so what is the effect of prescribing omeprazole to a patient who is already taking clopidogrel? Right, so the answer here is B. And again, just showing you how I draw these out. So omeprazole inhibits the CYP2C19, which is activating clopidogrel. So if you inhibit this CYP, so if you were to put an X here, you're going to have an increase in the amount of inactive drug. So like this is a good example of why this is important, because if you have a patient on clopidogrel, which is an antiplatelet, and you give them omeprazole, which is a very common drug, it's a proton pump inhibitor, so for something like heartburn, you can cause an increase in the amount of inactive clopidogrel, which, it's a blood thinner, so this patient could form a clot and, of course, the negative effects associated with that. Okay. So let me go backwards here. Okay, so let's go back. Okay, so I had a question about warfarin. Okay, so warfarin is an acidic drug, and the pH of the urine is less than the pKa. So this is so in an acidic environment is where the pH is less than the pKa. So warfarin would be unionized. Um, because if it's sitting in an acid, it's not going to give up any of its protons to make it unionized. Or, I'm sorry, to make it ionized. Does that make sense? Yeah. And honestly, the reason I said that we'd come back is I was like, oh, I've got to think about this. So, yeah, this is probably the hardest concept on the exam. Um, and when I do my review session next Sunday, I'm going to write some more of these. That way, you guys will be really good at it by the time you take your exam. Okay. Does anyone have any questions? If not, I'm done. Yeah, you're very welcome. Hope you guys have a good week. Yeah, you're welcome. Good luck on your OPB exam coming up. Yeah, I'll post the first aid PDFs. Um, Thank you for the welcome back. I really enjoy doing this, so I'm happy to be back. All right, I will see you guys on Wednesday.